So I'm Gino Fallone. As you can see from my affiliations, well, first of all, I got to thank you, Sharon, and everybody else for inviting me here today. So it's a great honor. So I'm both an academic at the University of Alberta as well as a clinical medical physicist at the Cross Cancer Institute. And I'm also co-founder and chair of something called MagnetTx Oncology Solutions, which is a startup of the Alberta Health Services, which owns Cross Cancer Institute and the University of Alberta. MagnetTx commercializes the entity called Aurora RT. That's how we had the Aurora pictures. That's from us. Which is a commercial version of the Alberta linac-MR. So I'm a co-inventor and co-author on all the patents and paper associated with the machine. So the first question is, why would anybody in their right mind try to merge a linear accelerator, linac, with an MRI when it was thought impossible because one machine does not make the other one work? We thought about that carefully. And the reason is to actually see what the problem is in radiotherapy. Radiotherapy is a very long process, and I keep saying, per patient is still the most economical. And remember that, all the young people. The cheapest cancer therapy is radiation therapy. So one of the critical aspects of this is when the patient is on the linac couch or table, what happens there, you have to position it properly. So the images from a CT look like this thing on your left. So the prostate is somewhere there. So the margin of error is quite large. Because the margin of error is large, that the amount of dose per treatment is lowered and the patient comes 20 to 40 times. That's why therapy comes so often. Secondly, you cannot image during the treatment delivery. That means you cannot image moving tumors, such as in the lungs, liver, pancreas, etc. Now imagine if you had an MRI, picture to your right, of the tumor, you could see it. Obvious then the margin of error is quite small. Because it's small, you could increase the dose per treatment, per session, significantly, and decrease the number of times comes to less than 5. And if you do it right, you can actually treat during the delivery. So you could treat moving tumors. So let's do it. So this gives you the history a little bit. People like to know this. So the original patents were issued, and then, of course, all were disclosed, but then issued later. So this is the original one, just to show you. It involved a rotating patient, rotating gantry. It involves something called perpendicular and parallel configuration. We'll see why I keep pushing that. It involves linear accelerator, linac. It also involves proton or particle therapy. Around 2018, we built the first system in the world, which is a machine that does both MR imaging and linear accelerator, giving irradiation at the same time. At the first one, we did it is called perpendicular configuration. Just remember that. And the image shows right here. So you got a beautiful image without each machine destroying the other. So it works. After that, we did all our expertise in what we call parallel configuration. And I'll explain why we're so happy with that one. So the first whole body system, I think, was one of the first in the world, if not the first in the world, was built at the Cross in 2013, Cross Cancer Institute. That allowed us to redefine the system, refine the design. Till around 2020 or so, we built the clinical one, again, at the Cross Cancer Institute. And that one there, around 21, received the Class 2 device certification by the CNSC. After that, the commercial, although it's the same one, but the brand of the commercial, the Aurora RT, received FDA. And this year's all of CE mark, Europe, Australia, Ukraine, etc. Other features will be submitted in the next year or so. So that's the history of our stuff. Before commercial, all the development, and still today, was done in a university setting, University of Alberta Cross Cancer Institute. This is how it looks right now. I think it looks cool. It looks like a nice machine. And thank you. So I just want you to look at these doors here. So if you open the doors, this is what you look at. This is the MRI and the actual inside the MRI. So the patient or couch comes in. There are lasers from the outside, and the couch goes in. And look at inside. So this could be a patient, or it could be phantoms. And the staff only will come in and actually walk into the magnet. and either talk to the patient if you need to. We've had cases like that that actually helped, or move the phantoms, their test objects, to make sure. The nice thing about this is that MR couches are not very accurate. So although you put a laser, adjoint the laser here, and you move it in, they move a little bit, the couches. Because in MRI, you don't need that precision you do, and accuracy that you need in radiotherapy. But then we've added a laser for positioning right inside the magnet. So right now we're doing a lot of clinical trial studies. Okay, so this is to see how to use the machine. And the names in red are radiation therapy, radiation oncologist with their own specialty. So we've done from imaging, simple treatments, and then more complicated and radical treatments. Dr. Usmani is the one running all the clinical trials. I can't because conflicts. I sell the machine, so I can't do that. So this is how it looks. So we do not use cylindrical MRIs. All the MRIs you see in the world are called cylindrical. You cannot use those. You got to use an open magnet, an open MRI, or what we call sometimes biplanar, 2 planes or 2 poles. So where are the 2 poles? One here and one there, 2 poles. Okay, and it's parallel, which is the preferred version, because the magnetic field in these things, see this black thing arrow, is parallel to the radiation configuration, obviously. Okay. The linac head is right here. That's where the linear accelerator lasts. Here is the multi-leaf collimator that shapes the radiation beam. This blue thing is called the magnet yoke, and it is designed such that the magnetic fields, different fields, are shaped such that you get the maximum uniformity here. And I make sure that the magnetic field with the multi-leaf collimator is essentially 0 to avoid focusing of electrons, what are called contaminant electrons, produced when the X-ray beam from the linac hits these MLC. That technical stuff, not to worry about. On the other side, we have what is a beam stop, which means, because it's a beam stop, it simply means you need much less radiation shielding in the room. One half the size of a regular linac. And it also is there as a counterbalance, because all of this, the linac, the MRI, rotates around the patient. So you need this as a counterbalance. This stuff here is actually a spool for the cables and this type of thing. So here it is at 0 angle. See, completely open. Now, when I rotate the magnet, I call that 90 degrees because it's 90 degrees up. In that case, when the patient is facing upward, inside the magnet, the patient sees the ceiling of the room. So obviously there's less claustrophobia. So let's look at this stuff, perpendicular versus parallel, and why it is critical to know whether the magnetic field, what affects the radiation plan. So that's why there's a physics part. So let's look at these 2 aspects. If you look at the cylindrical magnet, all the other MRIs, and elect as our competitor, the magnetic field, so it's cylindrical, there it is in this direction, the black arrow. That's how it is. The only place you could put the radiation beam is right here. Therefore, now that and that is perpendicular. Very simple. That's what's called perpendicular configuration. In our case, we could do perpendicular. Here's the radiation beam. See? The magnetic field, the radiation beam is perpendicular to the magnetic field. We could do that too, and our first prototype was that. But what we are doing now, we make sure that both are parallel. Why? Why am I pushing this? So let's talk about it. Here's a really old implant we used in the early days. Okay, there. So here's a 5-field plan. It's very standard. The radiation beams converge on the tumor in red. Now we put a magnetic field in there. So here's a perpendicular magnetic field. You look at the difference. You notice hot and cold spots. So the radiation beam is affected. What's that?
Pointer.
Yeah.
You're going to have to use that screen over there. So bring it over here. You see it there?
Oh, you guys don't look at my pointer.
Yeah,
Oh,
do that, okay?
there?
Yeah. Okay.
Oh, yeah, but I don't see it. No, I don't see it. Okay, I'll try to do it. No, I can't see the pointer. Okay, the image to your left. Sorry, thank you. The image to your left is 5 is 5 fields that concentrate itself at the center. The image at the center here, the image at the center, and I do not see that. Oh my God. You guys have good eyes. Yeah, you see, but I don't. The image at the center is okay. We'll forget about it. Yeah, this is getting too complicated here. Yeah, thank you guys. Sorry about this. You'll see red. The red is hot spots, and the straight lines there's hot spots, and the red occurs at the interface of tissue and lung, or tissue and air. So the dose perturbation is major, is very significant. And to do that, you have to do Monte Carlo calculations, which physicists love to do, but it takes forever to do, to be really accurate. And once you do that, then you have to mitigate, well, how am I going to change this problem? And that's a lot of the work, and the people use perpendicular, you're stuck doing this type of thing. In the parallel, the one to the right, you notice the difference is very small. It's basically, and it's only minor dose perturbation. It only occurs in the lung and air, very small. Now you know why we like the parallel. So we compared this now. Here's a RayStation is a commercial treatment planning system. We want to use standard ones. It does not take care of magnetic field, but we measure the beam with the magnetic field on, and the treatment planning system calculates it without looking at the magnetic field. And essentially the PDD, which therapy people know, and the profiles look exactly the same, with or without the magnetic field. The only difference occurs, slight increase when you put the magnetic field in entrance surface dose, a very small increase. So now we look at lungs. Okay, so this is a lung phantom, and we calculate, does the magnetic field affect the dose? It only affects it slightly by changing small amounts, which is actually insignificant in radiotherapy. But because it does a small change, then we are looking at doing a commercial system with the RayStation, which is a software for research, which is a Monte Carlo with magnetic field, quick. And we are now currently comparing it with our own Monte Carlo, which takes weeks. Make sure that the one that takes weeks is exactly the same as the one that does very quickly. And we see it's right on. So this will be the platform of choice in our system when you do the treatment planning. Now, does the magnetic field affect the dose? I don't know how many people here are radiotherapy physicists or not. I'm not sure. Assuming none of them are here. So, you may know that why you have medical physicists in hospitals and you don't have medical chemists. There's a reason why. Medical chemistry, the prescription is guaranteed by the company. In medical physics, the instrument, the machine, is not guaranteed by the company. The hospital does it. So the first job of a clinical medical physicist is determining the prescription of that machine, something that in drugs the company does. Okay, in determining that prescription, you need ion chambers. So it's called commissioning or quality control. So the ion chambers, here's a typical ion chamber shown here, is affected by the magnetic field. This is the response, relative response of magnetic field. So as the magnetic field increases from 0 to 1.5, you notice that as much as 10%, the dose changes by as much as 10% depending on the magnetic field. So imagine the trouble physicists would have trying to figure this out. All these ion chambers and the magnetic field is there. And it is. It takes 3 times more. So if commissioning linac takes 3 months, that's what it takes us. You have an MR linac, it'll take you 3 times, 3 months. And look at now you do our case, makes no effect. Chambers. Another proof, third-party clinical dose reference, just to show you as an example. This is required in clinical trials of radiotherapy. And the third party is basically MD Anderson or IROC. You got to make sure that when you measure this prescription the physicist figures out is actually correct. If not, they're completely off. So what is done is detectors are sent to the site. There's measurements done, and those detectors are brought back to IROC to make sure the 1 gray in China is the same as 1 gray at the Jewish. Okay, and those little detectors are called OSLs. or TLDs. You see them at the IROC TLD and IROC OSL. In our case, we use both of them, and way beautifully acceptable has to be anything below 5%. So it passed. If you use a cylindrical magnet, OSLs cannot be used. They're off by 10%. But in our system, you could use them. So you could see the magnetic field does not affect something very critical, which is, I think I'm giving 10 grays, but I'm not sure. Okay. So in parallel, that's why we do parallel. Now, the other thing was, okay, what magnetic field am I going to use here? Are there imaging medical physicists in the crowd? No. Okay, so I'm going to go from scratch. So, most medical physicists and MR specialists will tell you the signal to noise ratio, the signal, okay, goes up with the magnetic field, which is the same as saying the higher the magnetic field, less noise. You get less noise. However, SNR, signal to noise, is not the only deterministic of the quality of an image. There's also something called contrast to noise. And refer the expertise to radiation oncologists that says, look at a lung image taken by megavoltage X-ray compared to the lung image taken by diagnostic X-ray. Has any of you had done that before? No? You've seen a lung X-ray, right? You see the bones and all this. If you use a megavoltage image, in other words, instead of using an X-ray tube, you use a linac to take the same picture. There's no noise, but you don't see anything, literally. And there's all sorts of reasons why, but you see bugger all, use the expression. That's why you do lung at diagnostic, not at therapy, because you don't see it. In that case, the contrast is really low, even though the noise is also low. Same in MRI. So we looked at this. So for MRI, especially treating moving lungs, moving tumors, say in the lungs and or liver, you breathe, it moves because we breathe in the abdominal. All that thing is moving. You need very, very fast imaging, very fast MR imaging. So the fastest MR imaging is that thing called BSSFP there. It's a pulse sequence, is the workhorse. So now we say, okay, I'm going to use this sequence to do all our imaging. What magnetic field would I get the maximum contrast to noise? Your typical physicist will say, the higher is the magnetic field, the best. We said, no, not necessarily. So we did a study. This was, I don't know, 2015, something like that, and able to calculate what the maximum contrast to noise was with respect to the magnetic field for all sorts of organs. And we found, lo and behold, that it occurs at 0.5. And that is because the BSSP is very much a T1 weighted imaging sequence. I don't know if you know T1, T2s. Nobody knows? Yeah, somebody knows. Okay. So T1 is the difference between, so at the low fields, it's very high. I go to 0.5, it gets the highest. When I go down to 1 or 1.5, it goes down to 0. That's where you need T2 for imaging. So I have all these scanners here, it's a T2 weighted. But we're not going to use T2 for this. I need fast imaging. So we said, let's go 0.5. That's why we have 0.5. Here's how the images they look. All right. The one at the bottom to the right is 1.5 image. Beautiful, exquisite, less noise because the background is very dark. And the one on top is more noise. You can see more grainy. But the one on top, everything's so contrasty, right? So that's called more contrast. And why that's important, because when I'm imaging here very quickly, I need to do auto segmentation. You don't want a physician delineating all these images. There's too many of them. You can't do it. So it's easier to use the one on top to do that in software than use the one at the bottom. And that's why we chose 0.5. Something else we wanted to look at is not change the whole field, because you're inserting this MRI. Already we know if you don't carefully, you create those problems. But would it create other problems too if I put an MRI? Let's go back and look at a conventional linacs that we've been using for 40 years. What you see there on your left is a linac head, an old one, and it rotates around that couch. The patient lies on the couch. And the center of rotation is the isocenter. You notice I put dark arrows and red arrows. So MR couches, they're dark arrow, they do, but the red ones, they don't do that. So in an MRI, you cannot do that. So the question is, why would I need to move the couch? Well, in radiotherapy, you may spend a day or a week per patient doing the treatment planning and MRSIM to get the best orientation of the radiation with the tumor. So you got to move the patient so that the tumor is at a particular location called planned location, and you put the patient there for the best treatment. Okay, so that's why you need that motion. Now you go to a diagnostic cylindrical magnet on your left. There's no room to move the couch. So you can't do it. It is impossible to do it. And that does create a problem if you use a cylindrical magnet. And you do. People do have those, have major issues. You cannot move the couch. In our case, we have 110 centimeter. This is big. You're able to move the couch. So our couch goes plus or minus 23 centimeters sideways or plus or minus 23 centimeters up and down. Cylindrical magnet, you simply don't have the room. You cannot do it. So because we're able to do this, our system does not require online adaptive replanning for every single patient while the patient is waiting on the couch, which is something you need to do if you have a cylindrical magnet. And they are doing it, 45 an hour, and the patient's waiting there. As soon as he coughs or she coughs, you can start again. Simply because you can't move the guy sideways. And then things like peripheral tumors, you can't do it because you cannot move the tumor from the chest at the center. You can't move the couch. So this is how we do it. Excuse me. So by rotating the gantry and moving the couch, this is just a video. You notice in this case, the breast here is the target. So you notice I actually move the breast and put it at the center. And if I continue on, you could do the same thing on the other side. But you cannot do if you have a cylindrical magnet. You can't do it. All right. So these are very practical problems, which took us a while to figure out. Now, the next one, and what I'm going to talk from now on in, of course, is not FDA cleared because we have the machine doing all the treatment, so it's not cleared yet. But it shows you what we've been doing for a while. What we'd like to do in moving targets, here's an example of moving target. So you notice everything moves in there. That's moving target. So here's the lung up and down. It's been delineated by our auto segmentation. So as it moves. So what you want to do now is track it, follow it, and send the beam to that location only. Since this happens quickly, you have to do that really fast, right? So not an easy problem. So we use, some of the students came up with this nifty RT. So essentially, we do fast acquisition, tumor auto contouring. So we'll automatically contour the tumor, find the center. Then we have to predict where the tumor is going to be by the time I send the beam there. You know, you're there, but then as soon as I do all the calculations, I'm breathing, and the tumor's moved. So I got to predict, got to know how that particular patient breathes. Put that in. Once that's going on, all that software is brought into the real-time multi-leaf collimators, which are a bunch of little thin tungstens that shape the radiation to that of the tumor. And by moving these leaves up or down, you would follow the tumor. And you do this continuously. Nice problem to solve overnight. Cool. So to do that, for the last 10, 15 years, we've been using a lot of what we call neural networks in early papers, but now I call it AI because it's fat to call it. So we use artificial intelligence for the last 15 years. So we use that faster imaging without creating distortions. Obviously, the faster the image, the better to follow the tumor. To auto segment the tumor as well as a tumor tracking with prediction. We got to add all that. So we've been working on this at least for 10 years. This is a very old radiotherapy treatment planning process. Maybe I should have done it at the beginning because I noticed there's not that many radiotherapy people here, but now we're here. Now we got it. So this is the whole process that takes very critical. The one that's important for the artificial intelligence is what's called the treatment planning and MR sim, because that is where the physician delineates the tumor, delineates the critical organs, and they're able to get the patient's breathing. And that's already done now. So we use that data for each patient into our AI algorithms and use that for each patient. Okay, so that's where we do the artificial intelligence. Here's an example then. We were able to increase the speed by 2.5 times. So this is regular imaging, then we increase the speed of acquisition. In MR, when you do that, you create artifacts. Look at these. That's called artifacts. Using AI, we were able to get rid of the artifacts. Then I'm just going to do this quickly by adding what's called principal component analysis. We increase the speed without creating artifacts by 5 times. We get some more. Here we have some other AI technique, convolution neural network now. We're able to increase it by 10 times without any artifacts. Still wasn't enough. So now we say, what happens if the patient changes breathing a little bit during the treatment? So we incorporated what we call real-time principal components technique that actually takes care of that and corrects itself slightly as the patient may change just a little bit. And we were up to 8 or 10 times fast. So all of this is under development for the last 10, 12, but it takes longer for this to be approved by the FDA because you have the machine controlling the treatment. Auto segmentation now. We won't go too much into this. All I want to say is we have shown that the error in our auto contouring is comparable to intra and inter-observer errors, which is just as good as the physician doing the contouring. Okay, but automatically. So then it just goes right through. So we compared it with the physicians, and it's actually, normally it's 80%, 80 to 90 is considered really good. So all the numbers are around that area, which means we're just as good as the experts. Okay. Now, how do we do tumor tracking? So we did this feasibility test, told you at least 10 years ago, that proves that all these AI stuff that we put together actually works. This was done in our first prototype. So we have a phantom or test object that moves by itself. We build into the system, and then the test object or phantom is a gel that is sensitive to MRI. And on it, we have GAF chronic film. So the MRI picks up this gel, sends out the radiation. The radiation is captured by the film, right? Let's see that. So the MRI tells you where the tumor is, and then the machine sends out the radiation. Radiation hits the film, the radiation's been there. So let's look at the results of that. In one case, now we have non-target, so the target, non-moving target, so the target is not moving. Sure enough, it picks up the object and sends radiation to it, and there it is. Film picked it up. Now we have the target going left to right. And it picks up the other sides here, but it radiates everything. So healthy tissue is now being irradiated, which is what we do now. And this is typically called an ITV. So people in radiotherapy will know what I'm talking about. So that's the equivalent of an ITV. Now I track it, which means I follow this thing. We're almost there, but you'll notice it's blur here because we're behind, right? I mean, the target is there. I get an image, then it takes time to reconstruct the image. It takes time to centimeterly collimate and moves all those little leaves, then move with the beam. But that time, the target has moved. So I mouse behind it. And now we've used the prediction. Add prediction to that, and that's for every single patient is different. We noticed that we looked at, for example, 40 patients with breathing problems. They're all different, completely different. So you got to know each patient's, and we know that by the MR simulation process, which we do anyways. So each patient breathes that way. So that goes into the algorithm. When you treat them, that when you treat the patient, that training is only for patient A. Another patient comes in, it's a different type of training through MR Sim. Patients B, etc., and they go on this way. But because of that, we're able to be really accurate and precise with following the tumor. For people who are physically, I'm just going to go over this a little bit. This is just the specs of our system. So we use 120 leaves, what we call single stacked double focus. That's some gibberish stuff, what that means. But what's important here is basically we have two independent rotating Y jaws that the others do not. That just increases the number of options you may have to treat. A very large plus or minus 23 centimeters. Low. What's important here, we could install it in any room. Install it in any room. I would install it in any room. You don't need a vent. So you don't need the liquid cryogens at all. So you can put it at the center of a building. Other magnets, you have to be at the outside because you have a vent to come out. We don't have that because we use a high temperature superconducting magnet. High temperature superconducting magnet does not require that, which you could actually turn the magnet off and on if you want. Okay, I don't have time to show this. It shows you how we installed it to this vault right here. So see, I go to the vault. So the machine was installed through here, not through. If you use a cylindrical magnet like an MRI, you have to take the ceiling or wall off. You don't have to do it here because the ceiling or wall are this thick concrete. Okay. We've also sent our system to University of Dresden proton facility as the imaging unit for their stationary system. So it's there now for the 1 year. I also have a patent for linac-MR. People doing PET. If you want to talk, I'll talk about this, but it's both patented in US and Canada. Blah, blah. The team is here, large team, people in red who work with the company. This is the pre-commercial scientific support, about $25 million over 10 years that developed the system at the Cross Cancer Institute. Thank you very much, Lazaro.